Really? That's just my dinner. Oh, you did? I'm just not. I was taught my, once I get my exam done, then I'll focus on stuff. Also, we will go in, right? No. Okay, it's in that day.
All right. So, per my calculations, I think that today we will manage to finish up the reproductive system, which means that we will have time for a bunch of review on Monday before our exam, and then review for the final on Friday. So we should have a cushy end to the semester in here. Okay. All right, so let's do it. All right, so thus far, we talked about oogenesis and spermatogenesis. So as you're studying, you want to make sure that you can tell the differences between those two things. So you want to know how they're similar, you want to know how they're different and be able to talk about both. And particularly, we want to think about where and when meiosis 1 and 2 are happening, the changes that we see in that in oogenesis specifically. We want to be able to describe the ovarian cycle and the uterine cycle, how they pair up, and all the things that are happening during both of them. Okay, so we've talked about both the ovarian cycle and the uterine cycle. So now we're going to be thinking about fertilization, implantation, early parts of embryonic development. We're also going to touch and use our new understanding of what these parts of the cycle look like, what the menstrual cycle looks like, to think about how some contraceptive methods that you'll likely see in clinic or among people you know, how they actually work and how they match up with physiology. Okay, so here's a big diagram of what we have going on as we are thinking about fertilization and implantation. So here we can see the ovary hanging out here. So it's got its little ligament, it's got some blood flow, all that good stuff. Here we see those follicles developing from primordial follicles, ultimately into mature Graafian follicles. We see ovulation occurring. And then during the luteal phase, if we don't have implantation occur, we'll have that corpus luteum regress and get kind of reabsorbed. At ovulation, we have that ovule and some of the surrounding cells moving into the uterine tube or the fallopian tube. So here we see those fimbriae going into our uterine tube. Somewhere along the course of this tube is where we may see fertilization occur. So when fertilization occurs, usually happens somewhere around here. And then we have to have that fertilized egg move down into the uterus. So fertilization is not usually occurring in the uterus itself. Okay, so as we're moving along through the tube, if we're a fertilized egg, we're going to see cycles of division. So here we can see that we start with a zygote, which is just one fertilized egg. Then early on, we first divide into a 4-cell stage. Then in 3 to 4 days, we can see that we have larger mass of cells, not too many still, potentially a countable number, but not a specific unitary number. 4 to 5 days after fertilization, we start to see separation of that cell mass. So we start to develop like an inner cell mass and then an outer kind of surrounding region. And that's the state we're at as we move into the uterus and implant on that lining of the uterus. So here we can see that epithelium. So we have a lining of the uterus. We know that this is the endometrium. We've got this thickened endometrial lining because we've just gone through our secretory phase. We have some endometrial glands here growing. Our blood vessels are about to grow during our proliferative phase, so we can see those there. So as this group of cells is implanting here, we start to see that cell mass kind of invaginating, so like getting into the layers of the uterus here. So you can see the invasion of some of those cells into the endometrium. This is what implantation is. So we then start to increase the blood flow to this structure and see formation of the placenta for exchange of basically blood so that we can get gases moving back and forth to our growing embryo. Okay. So in terms of the steps, we're thinking about fertilization. It's taking place in that uterine tube, which means that the sperm have to get up the uterine tube, right? So we talked about the sexual response in males. We talked about the influence of the parasympathetic and sympathetic nervous system as we think about erection, emission, and ejaculation, right? But that only gets the sperm basically into the top parts of the vagina. So the sperm have to be introduced to the female reproductive tract, but then they need to move. So they need to go up, they need to go through the cervix into the uterus, and then they're going to have to swim up the uterine tube itself, okay? Because that's where the egg cell is hanging out, potentially to be fertilized. Okay. So this means we got to think about timing again. Okay. So it is the case that sperm are viable for about 5 days, right? So they don't die off for a little while. They got a little bit under a week that they can survive, which is good for them, right? Because they got to swim somewhere, right? So they've got a little time to do it. Okay. That's not the case for egg cells. oocytes are only viable for 12 to 24 hours. So they are going to die and degenerate and not be functional after a day, right? So as soon as ovulation occurs, the potential for fertilization, that window is only open for a little bit under a day, basically. Okay. So this means that when we think about the process of fertilization, we can kind of match those two time periods up in different ways. So since the sperm are viable for 5 days, right? This happens 5 days before ovulation, and the sperm are just there waiting around in the uterine tube when the oocytes get there, possible for fertilization. If ovulation has already occurred, kind of doesn't matter that sperm are remaining viable for 5 days. They got to get there in those like 12 to 24 hours. So we've got like a range of kind of times when we have the potential for fertilization to occur. Okay. It's also the case the sperm actually aren't capable, even though they're mature, of fertilization until they're actually in the female reproductive tract. So they've got all their parts, right? They've got the tails, they've got the midpiece, the head with that acrosome, but they have to undergo a process called capacitation. And basically what capacitation is it just like gives them the ability to like swim in a way that enables them to like get up the uterine tube and like beat hard enough to like break through the outer layers surrounding the egg cell. And this is based on changes in like chemical processes that happen specifically in the environment of the uterus. Okay. So as we're tracing through, ovulation, we have egg release, right? We had that antrum kind of burst, boom. The egg literally has to like pop out of the ovary, right? You see it breaking here through the wall of the ovary. It has to be caught by the fimbriae because we've got like a catcher's mitt here, right? We don't have a direct connection. Okay. So we've got some fluid movement causing that oocyte to get into the uterine tube, right? So this is how we can end up with like ectopic pregnancies. An ectopic pregnancy would be like if fertilization occurs like somewhere here, and then somehow this fertilized egg is like not even in the reproductive tract really at all. It's implanting somewhere in the wrong place, right? That's what that would be. So we need to catch the egg with those fimbriae, get them into the uterine tube. Okay. So we're then going to have some contractions. So peristalsis, so that kind of like smooth muscle squeezing flow is going to move that oocyte from the fimbriae down the uterine tube towards the uterus. So it's going to do this for a little while. So we're going to have this peristalsis happening for a couple minutes. And then we are going to have the action of some ciliated cells take over. So remember, cilia are basically kind of like cells with extra hairs on them, right? So we've got the movement of these ciliated cells kind of pushing the egg along down that uterine tube towards the uterus. So it takes 4 days, actually, to get all the way from the fimbriae and the ovary at the end of the tube all the way into the uterus. So this is not a super fast process. And it's somewhere in those 4 days that we need to meet up with the sperm. However, we're not going to have a viable oocyte for the whole 4 days, which is why we usually see fertilization pictured in these like earlier parts of the tube. So the parts closer to the ovary, right? Because if you last 4 days and you're getting to down here, probably likelihood is that ovule is no longer viable. Okay. Cool. All right. So that's where fertilization is happening. What's going on overall? So we've got literally millions of sperm being deposited into the vagina during copulation, during that mating act. The sperm are also swimming towards the uterus and the uterine tube, which they can do as we have capacitation occur. So they can live for about 5 days. They're swimming along. And actually only a few hundred of them make it to the uterine tube. So even though we've got, bless you, millions in the vagina, it's the rare few that make it even to the point where they could potentially fertilize an egg. Okay. So they're there. Maybe they can then fertilize an egg, but only if they've undergone this process of capacitation. So they have to interact with this different environment in the female reproductive tract to make them viable. And that's changing the movement of their tail. So they have changes to the movements of that flagella that let it kind of like beat harder, basically, as well as changes to the plasma membrane of the sperm, because they have to break through a sort of outer protective layer around the oocyte. And that takes a chemical process, basically. So they're changing their membrane as well during that capacitation process. Okay. So when we think about birth control, which if you're planning to be a healthcare practitioner of any type, you will certainly encounter, you can basically attack like any part of these processes, right? So we think about birth control with respect to pregnancy, obviously, but the different forms really work in different ways. They can target parts of the hormonal cycle. They can target fertilization. Potentially, they could target implantation. So it really depends. And so they're a good way of thinking about all the things that have to work together for pregnancy to actually occur, right? So some birth control methods are just going to prevent a sperm from getting to an egg, right? No sperm getting to an egg, then we don't have fertilization occur at all, so we don't have pregnancy. If you prevent the ovaries from releasing an egg in the first place, so like you prevent ovulation, there's no egg there to be fertilized, doesn't matter if sperm get there, there's nothing for them to do. You can damage sperm so that they can't swim to the egg, right? So their motility is important, right? And that capacitation process. So if you were to end up with sperm that are kind of slow and not very efficient and can't break through the outer layers around an egg, you wouldn't have fertilization occur. So that might also be something you think about when you think about like infertility issues, right? That can happen on either the male or female side from the reproductive tract perspective. We can also change like physical structures in, I guess I would say either the male or the female reproductive tract, but one thing that we can do with some forms of birth control is the cervical mucus that is changing through the course of the uterine cycle. We can trick the body into making that cervical mucus super thick, forming that plug that it does at the end parts of the uterine cycle because it thinks you could potentially be pregnant. If we thicken that up, maybe the sperm can't swim through it. So we're, again, kind of like damaging their ability to move and get into the uterine tube. Or we can change the thickness of the uterine lining itself. If we make the uterus as a whole just kind of like inhospitable, then maybe we prevent implantation. So different forms of birth control do different parts of this. And sometimes we have them doing multiple at once. Okay. So the simplest, right, from an understanding perspective is actually like forms of sterilization. And so when we're talking sterilization, we're talking about like literally just changing the anatomy so that fertilization can't occur because we have blockages, basically. Okay. So when we're thinking about female sterilization, what we would do if you wanted to be sterilized, but like keep your uterus, keep your ovary, we do know that estrogens are important for maintaining secondary sex characteristics. They're important for aspects of bone health, stuff like that. So you might want to do that. But you could get sterilized anyway. Keep all those parts, but you get a tubal ligation here. So all that is, ligation means like cutting something off. So what a tubal ligation is it's literally talking about that uterine tube. So we basically just tie it off, right? So if sperm get in the vagina, go through the cervix, go through the uterus, they're trying to swim out to those outer parts of the uterine tube towards the ovary, because we've got that oocyte hanging out over here, right? They're not going to get there. They're going to get into like the blunt end of this tube. No further, no fertilization would occur. Or you can think about it from the other side too, right? So ovary, ovulate, expel an egg, and it's just never going to get to the uterus, right? Tube's not open, nothing's going to happen. So that's why sterilization is so effective as a form of contraceptive. A vasectomy is actually a much easier procedure because to do a tubal ligation, you have to like literally do pelvic surgery, right? Like, so you have to open someone up, go through their body wall to get to those uterine tubes. I suspect you have seen those in lab, right? So that's kind of invasive, kind of longer recovery time. A vasectomy is actually super easy. They do it as an outpatient procedure. The reason it's so easy is that the vas deferens hangs out of the body, right? So you don't need to go through someone's muscles and get in there and reach at it. You can actually just get the vas deferens on its way back from the testes, right? So we have that vas deferens in the spermatic cord. So all they do there is, again, you can like ligate this. I think modern forms, they have an injection that just kind of like fills it actually with a block. So that's part of why they're reversible, really, is that they don't actually fully snip it off anymore, always, to my knowledge. I think you have one of the donor bodies in lab has a vasectomy, I believe, right? They staple that one shut, kind of. Yeah. So that was like from the 80s. I don't think they do that anymore that way. But relatively easy outpatient procedure and usually reversible in the modern forms. And we've got barrier methods. So these are also a way of preventing the sperm and the egg from meeting for fertilization to occur. We've got a variety of ways we can do that. We're literally just putting a barrier in there. So could have some form of plastic or latex, right? Either female or male condoms, either lining the inside of the vagina or the outside of the penis, doesn't really matter. You'd end up with the sperm caught in a bag, right? And then removed. We also have methods that go like right on the opening to the cervix, right? So if you imagine sperm deposited in the vagina, if you have like a block over the cervix, that also slows down or prevents fertilization as they can't get into the cervix and uterus and tube. So a diaphragm covers over that cervix. You can also have a sponge placed in there. Usually these methods are combined with some chemical methods for kind of disabling sperm, so like spermicides and other contraceptive gels to kind of make this more effective, or literally a cervical cap, just kind of capping off the top of the vagina, I guess capping over the cervix, as the name says. So those are Berry methods. Then we have hormonal methods. So hormonal methods, the ones that we use anyway, although they've tested out male birth control as well. But our hormonal methods usually target the female hormonal cycles. So as we mess with like estrogen, progesterone, LH, all these complicated endocrine basically signals that have to happen for ovulation to occur at the appropriate time, for follicles to mature, all that jazz. If we mess with that, then we are unlikely to end up with a mature, viable oocyte being released in the first place. So there are a number of different forms of hormonal birth control or birth control that contains hormones, which target different hormones in kind of different combinations. But these are some of the types of birth control that are getting at those hormones. So birth control, just the pill is attacking hormones, but so is the morning after pill. Various implantation methods are often linked with release of slight amounts of hormones. So the NuvaRing or the IOD, the Depo-Provort Aeroshot, or the implant. All of those are also releasing small amounts of hormones to kind of mess with the cycle, as is the Ortho-Evra patch. Okay, so we'll highlight first the birth control pill because it's one of the standards, right? Rather common in terms of hormonal types of birth control. So the way that works, basically, main thing is preventing ovulation. At least that's going to be true for a lot of birth control methods. So if you prevent the ovary from releasing a mature oocyte, there's nothing to fertilize. So birth controls can do that. And sometimes they do also prevent fertilization itself. So changing some of the aspects of what that process looks like. I'm not being super specific because there's not just one birth control pill with one specific formulation in terms of what chemicals it contains. But the most common one is a combined pill containing both estrogen and progestin. So there are combined pills and there are pills that only include kind of like one or the other. But this is the most normal version. And I think we have a picture of linking up why that would have this effect. As a side note, there are lots of other benefits of hormonal birth control, and particularly of this combined pill. So studies show that it basically halves your risk of ovarian cancer, as well as decreases substantially risk of endometrial cancer. Hormonal cycling causes a fair number of problems for like quality of life. Cramps that happen during the uterine cycle and during the menstrual phase, particularly as you're trying to expel the lining, can be really debilitating, as is premenstrual syndrome related to kind of like withdrawal from those hormones right before menstruation, anemia from the literal blood loss during the menstrual phase. So hormonal birth control, the birth control pill, kind of helps with all of those by stabilizing hormonal levels, basically, so that cycling kind of stops a little bit. So this can also prevent ovarian cysts from occurring, prevent symptoms of endometriosis, treat acne that often occurs alongside that like hormonal cycling. So hormonal acne or excessive hair growth, as hair in the armpits and the genital region is like one of the secondary sex characteristics that we develop during puberty. So excessive hair growth can be a kind of side effect of puberty depending on hormonal levels. Can also help along with ovarian cysts, right? So polycystic ovarian syndrome is lots and lots of ovarian cysts. So imagine instead of like one mature Graafian follicle releasing like one little oocyte, imagine like big giant bags, many of them forming in the ovaries. That's basically what happens with that. Okay. So what's happening there, right, is that estrogen, so there's estrogen in this combined pill, right? Estrogen suppresses ovulation because it suppresses the LH surge. So in order to trigger ovulation, right, we need that LH surge to occur. And we saw that in parts of our follicular phase, part of what is stopping ovulation, part of what is stopping those high levels of LH are that inhibitory negative feedback loop with estrogen. So as we provide estrogen in pill form, this stops the pituitary gland from releasing that luteinizing hormone. So without the luteinizing hormone, we're not going to have ovulation occur without that spike. And this also actually messes with the maturation of the follicles in the first place, as we think about that link between like LH and FSH and those growing follicles in the ovary. Okay. So here we just see a reminder of how these play together in our typical ovarian cycle, right? So usually we see during the follicular phase of the ovarian cycle, we see estrogen on the rise, LH like kind of stable until estrogen drops because of that inhibitory effect. As estrogen drops, LH spikes. So imagine you just keep that estrogen level high because you're taking it orally every day, right? We're just going to keep that LH level low, no spike, no ovulation. The progestin in that pill is targeting a different part of the reproductive tract. So the progestin is thickening the cervical mucus down here. So that cervical mucus is normal, changes color, texture, thickness over the course of the uterine cycle. But if you make it really, really thick, then it acts kind of like the cervical cap or the diaphragm would by blocking the sperm. So we've got a kind of like 1-2 punch with that combined pill, right? We're both blocking the sperm from getting into the uterus in the first place, and we're suppressing ovulation. So if they bypass that thickened cervical mucus, there's not a mature oocyte there for them to fertilize anyway. Also going to point out some risks of oral contraceptives. So there are many benefits to them, but I've found from talking to people in my life that people don't always point out when they're prescribing these things, that there are some downsides or some ways that hormonal birth control can fail. So this is my warning so that you don't become that kind of clinician. So one thing is that the typical combined pill can increase stroke risk. Not really a problem if you're a typical person who doesn't have any clotting issues, doesn't have any increased risk of clots. But this is something where you'd want to ask a patient like about their family history, because if you're already at an elevated risk of stroke because of blood clotting disorders in your family, then this might not be the best contraceptive for you or for your patient because of that increased risk. Other thing that's true is that even if you're taking an oral contraceptive, your patient decided this is the right form of birth control for you, there are a couple warnings on that label. Comes with a I think, a very, very long packet of information, but basically there are some ways that it can be kind of like disabled. So what it's doing, right? You're getting hormones, you're trying to keep stable hormones, we're suppressing that LH surge, thickening the cervical mucus. Okay. So if you don't keep that hormonal level stable by having that continuous hormonal dose, if your estrogen dips, that LH can surge. So if you have vomiting or diarrhea for more than 48 hours, even if you're on an oral contraceptive, you may be expelling either through the top or the bottom that extra hormone that you're taking, in which case you wouldn't have enough in your body necessarily to continue suppressing that LH surge. There are also various antibiotics and other medications that interfere with the function of various formulations, including even an herbal supplement that people might not think to tell their doctor. So St. John's wort. I don't actually know what that herbal supplement is for, but I do know that it can interfere with oral contraceptives. And it's also the case that when scientists do research, they often do it just on like whatever they've decided an average person is. So there's some research suggesting that these formulations really should take account of body mass a bit more because, you know, that's where you're distributing the hormone to, you know, potentially more blood, more mass. Might not keep those levels of hormones where you want them. So sometimes an oral contraceptive, depending on which one it is, may not work so well in patients who are significantly overweight. And this is true of the emergency contraceptive pill as well. So that this is one that's for a specific weight range. There are ones that people can take if they're outside of that weight range, but it's always important to actually read the information of the drug you're prescribing. Okay. So emergency contraception is usually still in the form of a pill, still a hormonal method. Basically kind of works the same, actually. So what's going on with the emergency contraceptive pill? The main thing it's doing is not like attacking a fertilized egg. What it's doing is, right, like we only have a 12 to 24 hour window where an egg is actually viable. So it's only if your patient happened to be unlucky enough that, you know, within that first hour or so, there already was ovulation right then, right before those sperm moved fast, and fertilization already occurs. Otherwise, those sperm can hang out in the uterine tube for 5 days, right? So if they're hanging out there and ovulation is going to occur anytime in the next 5 days, there's the potential for fertilization. But you can stop that. If the person hasn't ovulated yet, you can just suppress the ovulation and works the same from a physiological perspective as the typical daily hormonal birth control would. So what we're doing is just trying to suppress that ovulation. So suppress that expelling of the mature oocyte from the ovary. And that's what these formulations mainly do. Okay. So the current recommendation for doctors and patients is that the American College of Obstetricians and Gynecologists highly recommends people suggest the use of long-acting reversible contraceptives, by which they really mean intrauterine devices, the IUDs, and the contraceptive implant in the arm for contraceptive purposes. This is because they are particularly effective at preventing pregnancies, particularly because they don't rely on patients being absolutely perfect about using them at exactly the right time, Timing can be really important for birth control pills since we're trying to stabilize hormonal levels, right? Or barrier methods, using them at exactly the right moment, absolutely every time. If you use one of these long-acting methods, then nobody has to worry about that. So here you can see a study showing the percent of women who experience an unintended pregnancy in the first year of use for some of these different types of contraceptive. So here we can see what the combined oral contraceptive pill is like. So during typical use, that's going to be 9% of women will still get pregnant with that combined pill. Now, with perfect use, that does drop down to 0.3, but that means very exact timing. That means none of those other contraindicators like antibiotics or vomiting or any of those things come into play. So from the study, somewhat tricky to be a perfect user here. Versus our long-acting contraceptive methods like the IUD or the implant, right? You don't see a difference between typical use and perfect use really at all because you don't have to do anything other than put it in. And we can see that those numbers are real low, right? So more effective than the pill in the first place, although really all of these are negligible numbers. So in terms of effectiveness of birth control methods, we're going to just look from least to most. So there are methods that include just being aware of fertility. So you can tell to some degree if you're a woman where you are in your cycle based on temperature, based on cervical mucus, based on math. So that can, with training, help prevent pregnancy, but it's very not perfect because bodies aren't perfect. Bodies aren't always predictable. So it's not a super effective form of birth control. So here we can see the percent of pregnancies that causes. Here we have 24%. Spermicides on their own, so just like chemicals to kill sperm, also not super effective. Barrier methods are more effective. And especially in combination with a spermicide, those would work better. Then we have here other forms of birth control. Our long-acting contraceptives are up here at the top. So either permanent sterilization or these reversible implants or intrauterine devices. And then kind of in the middle here, we have the shot, the pill, and some other like hormonal methods and an additional barrier. So there's a range of effectiveness for different types. Of note, for those IUDs, there are both hormonal and non-hormonal types. So if anybody asks you how they work, you need to be kind of specific. So the hormonal one works similar to some of the chemicals in the oral birth control pill formulation, but it's much more local. And it's usually just the progestin. But because it's so local, you can really keep that level stable. It does do some other kind of local effects as well. So this works for, they've actually increased it, I think, up to 7 for some of them, but 3 to 7 years. The non-hormonal IUD is made of copper. So this is just based on changing the uterine environment and making it more inhospitable to sperm. It's basically kind of an inflammatory response that it causes. So this has the effect of making them not work. So we got a couple things going on here. So in general, a concern that some people have about IUDs is that they might be preventing implantation of fertilized eggs, but there's only a limited amount of evidence for that. And really their protective effects seem to be mostly because of blocking fertilization in the first place. It is true that occasionally there are pregnancies that happen with IUDs in place. I'm just telling you that because there are some crazy photos on the internet of babies being born holding IUDs. They're weird. So it happens every once in a while, but terms of how effective they are, much more effective than a condom, than a pill. Okay. So here we have those different parts of the cycle. Our final little bit of content before we go is just what would happen if pregnancy does occur, if fertilization does occur. So we saw fertilization is going to occur potentially in that uterine tube as the oocyte is traveling towards the uterus and the sperm is swimming up towards that uterine tube. We can have implantation ultimately in the uterus. At this point, we're going to see shifts to hormonal levels, right? So usually at the end of the luteal phase, we see a drop in the progesterone and the estrogen being released by that corpus luteum. The secretory phase that's increased all this blood flow and gland stuff in the uterus sheds the uterine lining as we have drops in these hormones, right? Okay. So if fertilization occurred though, we're going to keep levels of estrogens and progesterone high. So we can see them actually like increasing until right before parturition, which is birth, right? So right before birth is when we would have a sudden drop in those hormones. As pregnancy continues, right? So like over the course of pregnancy, those estrogens and progesterone do stuff. So they grow the tissue of the breasts. When we're thinking about estrogen, it's growing the duct tissue. Progesterone is growing the gland tissue. So we have both ducts and glands deposited in the fatty tissue of the breasts. We see estrogen affecting prolactin secretion. So that's another hormone that's going to be involved with lactation. We see the growth of the smooth muscle of the uterus. And we see this relationship with the production of the hormone oxytocin, which is actually really important in causing contractions during labor. So progesterone is keeping our proliferatory and secretory phase uterine conditions going, right? So this end part, right? And they're suppressing those contractions of the uterus right until birth. So you can actually see that progesterone falls first and then estrogen falls. So estrogen like takes over during labor because the progesterone is gone, which is why those smooth muscles in the uterus and that oxytocin can cause contractions so the baby is born. The other hormone that we see that's really important during pregnancy, and this is a hormone that you test for if you do take a pregnancy test, is HCG. This is human chorionic gonadotropin. And I think I saw a recent study that they think maybe it's this that's responsible for morning sickness as well. So you can see it spiking the most here during that first trimester, so the first third of pregnancy. Okay. So this is a hormone that comes from the placenta. So the placenta forms after implantation, feeding the growing embryo and then the fetus. And HCG makes that corpus luteum stay around, right? So the corpus luteum in the ovary usually degenerates, but if the placenta is making HCG, it's going to stay around and it's going to keep making estrogens and progesterone, which is what it does in the first place in the earlier parts of the luteal phase. So it's just going to keep going. And then the placenta takes over. So the placenta, after the first 2 months or so, gains the ability to make estrogens and progesterone. So the corpus luteum doesn't have to do it anymore after those first couple months. Placenta takes over, which is what we see or how we see these levels going up and up and up. So the progesterone is inhibiting all kinds of hormones. So that progesterone portion is really important. So it's suppressing the gonadotropin releasing hormone coming from the hypothalamus. It's suppressing LH and FSH coming from the anterior pituitary, which means we don't have an LH surge, which means we're not going to have weird stuff like ovulating an extra egg when we're already pregnant, right? So that's the function of the progesterone as well in these kind of early phases of pregnancy. Okay. This is just a zoomed in part of that chart. And so we can see what's happening right at birth as well. We see that HCG down to 0, the progesterone very, very slightly offset, right? Down to 0, and then the estrogens down to 0 at almost the same exact moment of birth. Cool. And that is where we are leaving it for A&P in terms of content. So when I see you next week, we'll be doing studying, talking about our final, our upcoming exams, all that stuff. Okay. Cool.